So welcome, folks, to another seminar in the HDR UK Applied Analytics series. I suspect most people in the audience will know how it works. It's very informal. I am simply your compere for the afternoon, and James is going to give the seminar talking about clinical PACS data. Not from Dundee, but from the US. So there you go. It's an international seminar series. James will talk to us for a period of time, and then hopefully be a bit of time at the end for questions, and we'll finish up on or before 4 if we can. So James, if you would take it away.
Thank you. Well, good morning for me and afternoon for probably everyone else. Good to talk to you today. I have just a few slides on this, so I would start with a brief introduction of myself. So I'm officially a data scientist and software architect at the Health Informatics Centre, or HIC, at Dundee University and Nine Wells Hospital. I've mainly been working the last 2 years now on the Pictures project there, a big MRC-funded imaging research project. I'll talk a bit more about that later. And also NCCID, the National COVID Chest Imaging Database. A bit more on that later. And two of my most relevant activities for today have been working on regional and national PACS feeds, pulling data from both the regional PACS that serves the Dundee area and also the national system in Edinburgh for COVID purposes. Previously, I did a PhD and lectured in computer security and forensics. And back in the dark ages before that, I did some image processing in Nine Wells on endoscopies. Let's start off. I realized that when I started in this post, a lot of people aren't that familiar with how the sausages are made, where these images actually come from, and how it all fits together. So the key to it, in many cases, is something called a PACS, which stands for Picture Archiving and Communication System, which is a mixture of a file server and a database server, in effect. It stores often millions of images. Our most recent projects pulled more than 35 million files for one single project alone, which, as you can imagine, is causing our infrastructure people some hair loss. And projects only get bigger from that. For Scotland in particular, there is conceptually a single PACS cluster that covers the entire country, although it's organized, there are devolved aspects for each region. So there is effectively a single archive of every MRI scan, every CT scan, X-ray, ultrasound, and almost everything else that's been done in any hospital or clinic in the whole of Scotland for the last 11 years now, all stored in one place in Edinburgh. There's a picture of one on the right, courtesy of Philips. That's actually a PACS system of theirs. They are, in fact, the company that runs the Scottish National PACS system at present via their acquisition of a company called Carestream, which wrote the underlying software. Now, the concept of a PACS started back in the early 80s when companies were making and selling MRI scanners, CT scanners, putting them into hospitals, and there was a need for a better way to organize all this data. At that stage, if you had an X-ray, often it'd be a physical film one that you would go into an X-ray room, they would stick a piece of film in it, expose it, develop it, and then your medical records would have a physical piece of photographic film in with your broken arm or whatever. And that was it. There was no computerization or automation. There was just a piece of film. And of course, MRI scanners, CT scanners are inherently electronic. So there had to be a computer involved somewhere. So that the early ones were, I think, just standalone devices that did their own thing. And fairly early on, there was a recognition in healthcare and manufacturing that this wasn't really the best way to do things, that they needed some sort of server to tie everything together and organize it all better. And in particular, provide commonality between MRI scans and CT scans. Obviously, they're physically different machines and different places, but they're doing very similar tasks, so it made sense to start grouping all that together. And so along came a standard called DICOM, the Digital Imaging and Communications in Medicine, which does all sorts of aspects of imaging. And the most relevant for us, it standardizes the network protocol, which is how PACS nodes talk to each other and how client devices talk to PACS, and the scanners themselves. So basically a standardized language and file format, which hopefully all of the equipment speaks and understands to some extent. And it standardized the file format in particular, exactly how those pixels get stored, and all these sorts of metadata, patient IDs, patient names, dates of birth, all sorts of other parameters that get tracked. And it's not quite a dessert topping FlowX, but it does encompass a lot of other aspects. There are standards for exactly how different levels of gray appear on screen. Obviously, that's quite important. That in medical imaging, a small shadow could be clinically significant or not. It's very important you have a very accurate and consistent reproduction of images. And it has standards for printing images out, putting on CD, moving around, all sorts of other things. So here's an example of a small part of one. It wraps up an image, often just a standard computer file format, like a JPEG or a TIFF that you might encounter on a website otherwise, along with a large array of metadata, which covers various aspects of the image. So this is one example, the patient ID. Obviously, that's quite important in clinical use. You want to be able to find by patient ID quickly. And rather than names, it uses numerical tags. So there's a hierarchy of these. So this patient ID, it's tag 00100020. And that's required, so there can only be one of it. And this should identify the patient in the scan. Seems fairly simple, but there's a very long string of literally thousands of these tags for different scenarios, some universal, like patient ID, and things like the manufacturer and serial number of the device which performed a scan originally, the date and time it was taken, and you'd have things like a study description, and you have notes, the name of the doctor who ordered a scan, for example. And the database aspect, you can usually search a PACS by most of these attributes. It's quite flexible in that respect for clinical purposes. So, as I note here, some of these tags are quite obscure and even undocumented. So, for example, Siemens or GE can put particular internal details of their MRI scanner or CT scanner inside the DICOM file using a private vendor tag, which officially nobody else knows about. And that's entirely for their own purposes. But typically for clinical usage, the usage is fairly simple. That you have a patient, and obviously you know who the patient is, you know their ID or name, and you search for that and just pull up typically the most recent scan. So that's a very simple use case in technical terms. Unfortunately, it's pretty much the opposite of what we want in research. We specifically don't want, even if we have Bob Smith's scan, we specifically don't want to know that it is Bob Smith's, or his date of birth, or his address, or any of the other things that a hospital would normally keep track of for a patient. We flip from regarding them as patients to anonymized subjects considered within a larger cohort. Often we aren't interested in the latest scan. Quite often we're interested in the oldest available scan for a particular subject. We have, for example, a dementia study that's looking at longer term prognosis and progression of disease. they are specifically trying to find the oldest possible MRI for each patient, and then looking for any early warning signs and how the disease might be progressed even before it was diagnosed and detected, if there were early warning signs could, with hindsight, have been picked up on. So as a researcher, you might want all the contrast CTs of patients with a glioblastoma. Well, that's fine, except the PACS doesn't know about glioblastomas. That's a diagnosis. That's not the PACS's job. So we need to link to external databases. So in that case, for example, there's a cancer database which records when a patient is diagnosed with a particular condition. So we can use that to generate a list of the patients who do have this particular condition, and then match that by patient ID, and then filter out just the CT scans, and then we can filter within that for just the images that used either contrast in general or a particular contrast agent that's relevant to your study. Now, it's a mixed blessing. DICOM files are extremely versatile. They can contain almost anything, including, as someone pointed out fairly recently, they can actually include malware, which perhaps a little too flexible in some respects. We actually have a possible research project coming up on that in the near future. I'll talk about that a bit later on. Now, as a network protocol, this is fortunately one of those details that researchers usually manage to avoid, but it's a dirty job that somebody's got to do. It's a very old network protocol, which started with a committee back in 1983. So if you think back then, computer networks were rare and new and not standardized at all. It wasn't until version 2 that the standard got as far as talking between machines over standard serial ports. Still no networking at that stage. So in some ways, the standard we're on now, which happens to be version 3, shows its age. It has no authentication in it. Passwords pretty much hadn't been invented yet, or nobody saw the need for them in hospitals at that stage. Encryption is just an optional extra. It's essentially a peer-to-peer protocol. It's built around an assumption that any node can communicate directly with any other node. So it seems like a fairly flat network without things like firewalls getting in the way and pesky things like IP addresses changing. It just assumes everything has a static IP address if you're using IP at all. It's a bidirectional protocol, which modern protocols tend to be client-server. That's, for example, your web server will connect to Google, send it a request, and get the response back over the same outgoing connection. Google doesn't have a way of making connection to you because you're not a server. And these days, often you're behind NAT or a firewall, so that connection couldn't happen even if you wanted it to. This is quite similar to the original or active FTP protocol, which is pretty obscure now. Most implementations use what's called passive FTP, where the client makes all the connections all in the same direction, which simplifies things like firewalling and NAT. The naming scheme in PACS is actually fairly similar to the original email addresses back before the @ symbol was added. You would use what's called bang paths. So you might have a user account on, for example, University of California, Berkeley's VAX system, which was called UCB VAX. So you might be, John ! UCB VAX, and then someone could send an email to you by figuring out how their system should connect to UCB VAX. And you'd end up with several paths, each with exclamation letters or bangs in between them that detail the path from you in, say, Edinburgh to some common point, perhaps in London, and on to UCB VAX. It makes you appreciate the @ symbol, and DNS came later. within DICOM, probably mentioned this earlier, there's a hierarchy. So you have a study, which will be often a group of scans that are related in some way. You might, for example, have both a PET scan of somebody with cancer, where that highlights tumor activity, and an MRI scan of the tissue the tumor is in. So that series, the MRI scan, for example, is a series which might consist of 64 or 128 separate slices, each which is an instance or image. So you group that into a series, which is the scan, and then you could combine those two series together into a single study, which is your cancer scan on a particular date. In the protocol, there are 3 commands that are particularly relevant to us, and minor ones like C echo, which is just checking connectivity between 2 sites. It's equivalent to a ping in normal IP networking terms. The most complex for us and most powerful in a sense is cfind. So you can send a search request to the PACS. I'll talk a bit more about those next. And then once you've found or identified your target, you can send a cmove request, which asks the PACS on the other end to send a particular scan or set of scans somewhere, which will be to another AET, another PACS node, usually yourself, but the way the protocol is set up, it's not necessarily you. The idea was that, for example, you can equally easily ask for scans to be sent from your hospital's PACS to another hospital or another department that has a separate PACS, and that works in exactly the same way. And there's the related cstore command, which is how you upload data. When you send the cmove command to the PACS, it will respond to that, assuming that the request is accepted and works properly, by sending a series of cstore commands to the PACS to the destination PACS, which transfers the actual data. Now, move on to all the technical challenges of doing this for research purposes. The first one is not so much a technical problem, more of an organizational one, that when we talk to PACS, this is a live clinical system, and the systems it's on and the people running it do it for clinical purposes first and foremost, not for research purposes. So whenever we approach a bit of the NHS wanting data from PACS for research, it's not their top priority, and it's not necessarily even a priority. It can be something of an inconvenience to them, and they are understandably very concerned that we must make absolutely certain that whatever we do doesn't interfere with clinical usage. So usually we run these requests overnight during quieter times for the system. And if there are any problems at all, we can have access cut off. And this has happened a few times with our regional PACS feed for various reasons. Anytime there's a possible technical issue with the PACS, performance problem, or signs of data loss with another PACS user, one of their first fault finding steps is switch off our connection and see if that helps. Because to them, research usage is almost expendable. Their priority is to maintain clinical service at all times, understandably. For example, our national PACS access is shutting down over Christmas just in case. There's fear on that side that there might, hackers might try to exploit skeletal staffing over Christmas and attention being elsewhere to launch an attack on NHS systems. So they're shutting down everything they can over Christmas, which means for us, that's a 3-week interruption in our data access. But when we do have access and are able to use it, there are some very strange oddities in the search protocol. For example, if you specify a date and time window, 9 a.m. Monday and 5 p.m. Friday, in the DICOM standards that can be interpreted as a total of 40 hours, 9 to 5, Monday to Friday, as a working week, rather than the way you might view it in a normal database search. If you specify a start time and an end time, you would expect a window of 104 hours there. And in fact, now that there's an optional extension to DICOM that you can link the time and date, so you get the 104-hour interpretation of that rather than the 40-hour version. But of course, because that's optional, you can't rely on the system you're talking to understanding that optional extra. There are all sorts of little complications like that. So your searches are a very complicated, multi-layer construct in some cases. But often it's best to try to keep it simple. Now, the other issue, once you do get access to the scans and you manage to retrieve the scan, you may find the priority is on clinical usage. So, for example, a radiographer is focused on getting a good quality, usable X-ray or CT scan of the patient and getting it to the doctor who asks for it as quickly and efficiently as possible. They don't tend to put much effort into, for example, annotating it. So we have a scary number of Brian scans where you're actually looking for a brain scan, which it's one of the many details that doesn't matter clinically. If a doctor is looking at a patient with a head injury and they're handed a scan of the patient's Brian, they don't care. They just look at the content. But of course, as soon as you're trying to index and search this, even a little typo like that can be a barrier, because of course a search for brain won't match that string. They're different words, which of course makes indexing this data for research purposes more difficult. It's also a problem when you're scanning for identifiable data. I'll mention that in a moment. And as I hinted at earlier, the issues you need to link sometimes with data that isn't in the PACS system. You pull information from other sources as well. So our colleagues in Idris in Edinburgh have access to a lot of other NHS databases that track things like diagnosis, patient demographics, deaths, hospital admissions, and allow some of this linkage. So in this example, which is actually a genuine research request from an oncologist in Cambridge early last year, they wanted particularly T1 MRI scans of the heads or brains of patients with advanced glioblastomas. It's a particular type of brain tumor. Now, the PACS has got all of the MRI scans, that's fine, but it doesn't know about glioblastomas. You need to pull another database for that. It doesn't know necessarily whether a scan is a head scan or not. And of course, even if it's accurately marked, there are a dozen different ways that a head or brain scan could be described: head, brain, skull, cranium. And any of those or none could be used for any particular scan. So within Pictures, we have a research project underway to help address that and try to identify the body part in each scan. On the right here, you can see some images that were submitted to the National COVID Chest Imaging Database. Medical technology might be able to see why the bottom right set of lungs doesn't work very well. It seems to have a pair of hip replacements in it. But that was submitted to us as a chest X-ray. So quality control can be something of an issue. So I've gone through a lot of interesting technical and non-technical challenges that you face trying to use real PACS data. There are various tools you can use to help address these. There's the DICOM toolkit, which we've been using, and in particular within HIC for the NCCID project, we've pulled around 25 terabytes of chest imaging data now for that database I mentioned earlier. And then we do more filtering and anonymization on that later. There's the RDMP DICOM project, which you can find on GitHub. That's an extension to a plugin for HIC's research data management platform, which is HIC's data management tool. And we've been using that tool now for just over a year, pulling nightly feed of all of the data within the Tayside or Dundee regional PACS. And that's been working pretty robustly now for a year, with I think one interruption was due to an actual malfunction as opposed to organizational issues. But the common solution to all these challenges for research purposes usually is to fetch a copy of all of the data you can get to from the PACS, and then either anonymize it and then index what's left, or you index the information in there and then anonymize the bits you're using, depending on the situation you're dealing with. And you can link it against other data to generate appropriate cohorts. And the biggest one we have is the SMI, Scottish Medical Imaging Project. That's an archive of something like 3 petabytes of raw DICOM images pulled from the Scottish National PACS system, spanning 2010 to September 2018. And there's work ongoing to bridge the gap between that and now. There's a smaller data set within HIC, which covers the imaging in the 9 Wells Dundee PACS. So it's only local data, but we have all of that from late 2019 up to roughly the present day. So that can be useful in itself for more recent imaging. And most topically, we have the National COVID Chest Imaging Database, a UK-wide project to gather as much chest imaging data as possible, along with the associated clinical information. So it's quite a large and complex project to pull information together. That's involved a lot of organizational work to get appropriate approvals in place, and then also technical work to gather all of that data together and link it in a usable form, while also anonymizing it and guarding against identifiable data creeping in. We saw 4 of the, what should have been 4 of the chest x-rays in it earlier. Those are all examples from England, where they have quite a different challenge from Scotland, where Scotland has a single nationwide archive of all the images. England just doesn't. There isn't that common platform. Each NHS trust or hospital has its own isolated PACS and no direct connection between them. So at the beginning of last year, when NHS England started this project to gather all of the chest imaging they could, nobody had access to all of those PACS systems. They would have to go around hospital by hospital asking the radiology departments to please send all their COVID chest imaging to a central point. So that's quite a challenge. They ended up, the Royal Surrey Foundation Trust set up a server for all the other hospitals in England to send their data to. And they went around getting relationships and technical connections to every PACS they could get to in England, and that's ongoing as they go around talking nicely and twisting arms of different hospitals across the whole of England, one by one, to get them starting to send data through. They do that, in fact, through the separate system from Siemens called the Image Exchange Portal, which is a service for transferring data between PACSs. So there's a huge amount of work in that, and the presentation I have from my colleague Mark, who works on that, said they have, I think, 33,000 images at the time. In Scotland, of course, where it's all gathered together in one place, we've already managed to pull millions. So we have very much the opposite issue. Because it's all in one place, it's very easy to access a huge amount of data. The problem then is trying to organize and transfer on that sort of scale. We also did a smaller special purpose project where we pulled all of the cardiology images. And this, of course, this is where we get into the small print that Scotland has a single nationwide PACS that has every MRI scan, CT scan, X-ray, all the others from radiology. But then cardiology departments are apparently a law unto themselves. They like to have their own separate PACS, which isn't connected to anything else, or has limited connections for various reasons. So that was a completely separate system to connect to for that particular project. It spoke the same language as a radiology PACS, but it had different data in that could only be obtained by talking to cardiology and was needed for that particular research project. It's been interesting talking to non-radiology departments about their imaging needs. That DICOM has evolved over the almost 40 years it's been in operation. It's extended. There's even a security variant, DICOS, which handles things like airport baggage CT scanners, because obviously those are CT scanners, but they're just being used in a different role. So there's a slight variation of DICOM for those purposes. And DICOM is expanding in modalities. We've focused largely on X-rays, MRIs, CTs, but it does cover a wide variety of other modalities, like PET scans, and is constantly expanding things like dental X-rays. And one of the next frontiers for it is moving into medical photography. Again, they currently do their own thing. They take photographs of people's rashes, skin lesions, that sort of thing, and they currently store those just as regular photographs, like you might on your Flickr account on Facebook. And there's some work underway to bring that on board with the standard that other medical imaging uses, structured better with DICOM, which would make research more efficient. Great commonality with things like anonymization tools. But there's a little resistance there. There's a fear that sharing a single central system might be slower than the system they're accustomed to within dermatology departments. There's a fear of the loss of control that they have at the moment with having their own isolated systems. So there are organizational politics to deal with there, as well as the practicalities of just developing useful tools on a technical level. So I mentioned some of these earlier, the various projects that are ongoing at the moment or in the near future. We have SMI. This is now a live service in conjunction with Idris from Public Health Scotland, that you can now go to them with a research project and get sets of anonymized images, CTs, X-rays, whatever suits your project, along with associated clinical data, released into the National Safe Haven in Edinburgh for research projects. So there are some of those already underway now. That, I mentioned earlier, currently has all the radiology imaging from 2010 up to 2018. And we're working now on trying to extend that up to the present day. But there are a lot of technical and non-technical hurdles in getting that in place. There's the Pictures project, and a website for that I've mentioned there, imageonamission.ac.uk, which consists of various work packages working on improving tooling and developing the SMI service with enhanced capabilities. We're also within that working on improving national safe haven facilities in general, developing new tools and security methodologies for handling research data, exporting it safely. So some publications already and more on the way. I mentioned the NCCID UK-wide COVID chest imaging research. That again is now up and running to some extent and has a rapidly growing archive of imaging and associated clinical data. So you can get COVID and non-COVID chest images, and the main focus is on training AI models to assess either the extent of COVID injury or the progression of a disease and perhaps prognosis. I just mentioned the dermatology use of DICOM in the near future, that they are starting to want to automate and organize their imaging beyond just looking at a patient's rash. They want to start doing large-scale imaging research, and you need, and of course the best way of doing that is to build on the existing work that's been done for other DICOM images. So I hinted earlier, there are some security issues with DICOM, including the possibility of embedding malware in it in all sorts of fun ways. You might know that from the general internet that it's not particularly safe to open just for example, a Word document. If somebody unknown sends it to you, there can be things like macroviruses in there and other malware. So be careful of opening Word documents. Word, to be fair to Microsoft, does now have various safety precautions in there against the worst of these, like macroviruses. It will at least warn you before you open a virus now. But there have still been various exploits and issues with Word over the years. DICOM is, I would say, in an earlier stage of this at the moment, that partly because these systems are very isolated from the general internet, there hasn't been as much work yet on all the nasty things that could be done with a DICOM file. But we are starting to look at that possibly and as a PhD project next year. Going into pictures. We also have a collaboration with the CMIH group, Cambridge Mathematics of Information in Healthcare Hub, where we're developing an automated live data exchange with a PACS, which is quite a change from the current research feeds, where you just do batch fetches of essentially historical clinical data. But we're moving into real-time diagnostics for this. And the most exciting, or possibly scary from a governance and regulatory point of view, is sending data back to the PACS, which I haven't mentioned before. Taking, for example, a lung CT, annotating it to highlight and measure COVID injury, and quantify that, and then sending with the annotated segmentation back and some sort of diagnostic report on the status of this patient's lungs. The clinical members of that group are very excited about that automated capability, that's being able to take a scan and get an automated measurement of the state of the patient's lungs, where exactly is the damage more focused to the left or right lung. They can adjust things like ventilation and patient positioning accordingly. But of course, that crosses from research into diagnostics, which opens up a whole new can of worms for governance and liability questions. Does anyone have any questions? Okay. Right. So first question, are we extracting the data from PACS or the original imaging device? The answer is the PACS. So the original imaging device doesn't store the images. It takes the scan and then uploads it to the PACS for storage. And then all access to that is done through the PACS after that. Even the radiologists in the hospital wouldn't talk to the imaging device itself. They talk to the PACS to access that data afterwards.
Thanks, James. This is Ramasa. Thanks, James. This is Ramasa. Great talk. I had asked that question and I had a follow-up question. So I work mostly with retinal images. And so when those images are transferred from our device, so we typically store our images in the device. And when they're transferred from the device to PACS, they seem to lose some of their features. So that's why I was wondering if that's an issue you've come across, or if you have any experience working with retinal images at all. Our images do end up in PACS, but I don't know if they carry all their original features.
Right. all the metadata should be transferred, I would think. I haven't worked with written data myself. We have some colleagues who have done on the Vampire project and others in Dundee. Could you give an example of something that you lose at the moment?
Sure. Like, for example, our OCT files, they're not in DICOM format. They're like .e2e files. And then when they go into PACS, it looks like we have the PDF report, but we don't actually have the image, the raw image to manipulate for analysis.
Right. So that's an issue. I suspect it's as simple as that the OCT itself isn't being transferred. One of the things PACS can store is a PDF. And it sounds like your system is just uploading the final PDF report, not the raw imaging. I don't know offhand if there is a good way of getting the OCT uploaded at the moment. If there isn't, it should be possible, but it may need someone to develop that modality. As with dermatology, that's a fairly new area. So tooling for uploading to dermatology.
We'd love to chat with you more offline. I don't want to take up all the time, but if you have your email, I can reach out.
Right. Luke asks if all the national PACS data is available. We are expanding the time window and modality. I think as of the launch a few months ago, we had a 3-year window of X-ray, CT, and MRI data. And we've got other years working their way through the pipeline, and we've got other modalities on the way as well, and things like I think ultrasound is quite a way down the list, but things we've added PET scans, fairly recent, and nuclear medicine. There is work ongoing to expand that to other modalities as I speak. So if you have a research need, you can ask an Idris in the first instance exactly what you need. So they're keeping track of what people need from them and trying to prioritize accordingly. So essentially, it will all be available. A subset is available now, and we are expanding that subset as quickly as we can. So yes, if you need access to any particular subset, a particular year, or a modality that isn't yet covered, you can ask about that, and then we can see when it would be available. Okay, any more questions or?
More questions for James? You can shout if you like. If there's anything. So I think I think, James, that that we're now done. So thanks very much. That was actually I hadn't spent a long time hearing about PACS, but I hadn't realized I hadn't understood it in depth. So now I do a little bit more. So it's good. So thanks again very much, James.
Actually, to say, my colleague Rory's just pointed out that there isn't very much retinal imaging availability at the moment. I seem to remember we had some discussions about this a while ago, that there are some issues with getting all of the retinal imaging from Scotland, that a lot of it is done in things like opticians' clinics and not necessarily uploaded centrally. So as Rory mentions, that there is some work to remedy that and gather the images together. I don't know OCT offhand, but I can ask about that.
Good.
And I'll try and talk to Ramasa more about that later.
That's terrific. Thanks.
So,
thanks, James.
Great. Thanks.
Okay.
So,
and so you have my email address if anyone wants to talk more.
That's great. That's great. Thanks, James. Good. So that's it, I believe, for this calendar year, folks. Thanks everybody for attending, and enjoy your winter break. See you in the new year. Bye.